Hello and welcome to Better Living for Better Health. I'm Melody Nall, the Cancer Control Specialist with Kentucky Cancer Program. Today we're going to be talking about colon cancer. Colorectal cancer is the second leading cause of cancer death in the United States. Almost 150,000 people will be diagnosed with this cancer this year. Over 55,000 people will die. In Kentucky alone, 2,300 cases will be diagnosed and 910 people will die from this cancer. But colorectal cancer is also one of the most preventable cancers. Over 90% of all cases could be prevented through proper screening methods. I have two wonderful guests here today who are going to share with us the importance of screening. I have Dr. Russel Carter with Bluegrass Gastroenterology here, and Dr. Denby. We are so glad you're also with Paducah Gastroenterology Associates. We'll make sure we get all of that in there. And I'm so glad to have you here. Thank you for being here.
Thank you. Glad to be here.
We'll start out with the basics, and let's just start. What is colorectal cancer? Either one of you.
I guess I'll start. It's a cancer that evolves either in the colon or in the rectum. The colorectal area is anywhere in individuals from 6 to 7 feet long, and it usually develops from a small polyp over the years, grows into a cancer.
Okay. And who is at risk for colorectal cancer?
Well, everyone's at risk. The risk gets higher as you get older, and that's what's so important. You know, we spend so much time talking about lung cancer and prevention with stopping smoking, but everyone's at risk for colon cancer. Some people are at higher risk than others, and some of that has to do with genetics and other factors, but overall everyone at least at the age of 50 needs to get a colonoscopy to make sure that there aren't any polyps.
Okay. I've also heard women tell me they think that this is a man's disease. Is that a true statement or is that a misconception?
As Dr. Denby has suggested, I think everybody is at equal risk, and it really doesn't matter whether man or a woman or white or African American, Hispanic. I think it's known that everybody is at almost equal risk.
Right. And I think our statistics, especially here in Kentucky, bear that out as well, but it really disturbs me when I hear women say that, so I wanted the experts to make that statement here today. We were talking about some people being at an increased risk. Who would that be?
Basically, if you have a family history of colon cancer, polyps, there are some familial cancer syndromes as well which put you at higher risk. Those people would need to be screened at an earlier age than 50. The thing I'm going to hammer home today is 50 years old at least, you need to get your colonoscopy. I think Dr. Carter would agree, we're finding way too many colon cancers. We'd much rather find them in the polyp stage than to deal with the cancer stage. And that has to do with the adenoma-carcinoma sequence. You know, they form in, the prevailing wisdom is they form in these polyps. And as those polyps get larger, more mutations occur. And if we can get them when they're smaller polyps, everyone's happier about that.
What would the length of time from a polyp occurring in the colon until it might develop into cancer, what would be the average time?
Current thinking is 10 years.
10 years, right.
10 years, okay.
There's some thought that maybe a little bit earlier in certain high-risk people, but pretty much 10 years.
And you also mentioned about other people that may be at higher risk, people with a history of ulcerative colitis. Those individuals that have ulcerative colitis for a prolonged time, maybe more than 10 years, certainly more than 20 years, if their colon is affected by this autoimmune disease, ulcerative colitis, or even Crohn's disease of the colon, these people are also at much higher risk than the average person. So.
Now, is that because the lining of the colon is just at a state of irritation and the cells change, or?
That's up to debate.
Oh, okay.
We just know there is a risk. We don't really exactly know why.
And in fact,
partly to do with that.
And in fact, if those people, we've had studies that are under good control and their inflammation is under good control, they still are at an increased risk. So you would think that, you know, if it was related just strictly to the inflammation, if you control their inflammation, that they would not be at higher risk, but that's not necessarily true. So.
Okay.
And that's what seeing a gastroenterologist is good for. There's certain things, you know, we list out, making sure that we minimize, you know, we know the risk to get the proper screening regimen down. You know, depending on how much the colon's involved impacts it as well. But that's what seeing a good gastroenterologist is good for. You sit down and talk to them about that, and they can tell you the risks.
Have that dialogue with your physician. Absolutely. Well, let's go ahead and talk about screenings, because we were talking about polyps, so we want to know, how do we find the polyps? And I know sometimes people get embarrassed with this one, but if you would just walk me through what the screenings that are available and what's involved with that.
You want to take that one?
We can tag team.
Tag
something.
team, yeah.
Go ahead if you want to.
Well, the different type of screening modalities out there is screening your stools, looking for sneaky blood. It's called occult blood, is one that's out there. It's typically used as kind of a first line in some centers and things. There's also flexible sigmoidoscopy, which is kind of fallen by the wayside because it only looks at about a third of the colon. Then there's these new genetic marker tests that look at the stools as well. But again, as we start going through the process, and I gave you a little bit of information, that pamphlet I gave you, but there's goods and bads with everything. And there's certain things we'll miss, some polyps, and certain things that, like a colonoscopy in some ways is, it's kind of an ordeal. You go through a day of preparation, and then you do the colonoscopy, and there's risks and benefits with it. But right now, it's state of the art in regards to the gold standard for finding polyps and adenomas.
The other options that people may come across, barium enema, which is an X-ray. You put barium up inside the colon, take X-rays of the colon. You're taking basically pictures of shadows of potential polyps or other growths within the colon. Problem is that's not as sensitive as a colonoscopy, and then if you do have an abnormality on your barium enema, usually he or I have to end up having the patient undergo a colonoscopy to try to figure out if that abnormality is real or if it's just a shadow on the X-ray. And then the other thing that probably 3 or 4 years ago that was kind of the thing that was going to change this whole world was having a CT of your colon.
Right.
And what we've realized now is that sometimes that also gives false results and ends up resulting in a colonoscopy. And the problem with a barium enema or a CAT scan is that you can't really remove a polyp if you see it. And that's, I think, why colonoscopies have become the gold standard, is not only are they diagnostic, but we can actually therapeutically remove a polyp while we're in there.
So that way the patient doesn't have to have a more invasive procedure.
Right.
Or a second procedure if they used one of the other screenings.
Or a second preparation
yeah.
and a procedure.
Yeah.
And that's one of the things that keeps people from seeing us.
Yeah.
sometimes.
In fact, would you kind of discuss what the prep is for a patient when they're going to be coming in?
Basically, to sum it up, is what you eat is typically what we don't want to see in the colon. And so the first day is usually just a matter of decreasing the amount of food you're eating, changing it to clear liquid diet and different things so it's easier to clean out. And then we give you something to flush you out. And there's different, seems like there's more and more preps available every year. But really the premise is still the same. You've got to flush out what's in the colon so we get a good look. Every time there's stool in the colon, we take a look. And if it's in the colon, it could be hiding a polyp. So the prep is vital to getting a good look.
So if you're going through this anyway, make sure you follow your doctor's recommendations so that they get a nice look at the colon and they can see everything they want to see.
Most patients are fairly frustrated when we come out and talk with them that we have to have them go through another exam or another day of preparation. So it's probably best just to get it done the first day and do it right.
Do physicians choose which type of prep? Is it just a personal preference, or does that depend on the patient? I hear people say that sometimes they have to drink a gallon of fluid, sometimes they don't have to drink as much, but they take pills. And is it?
I think it's a lot of physician preference. I mean, we're the ones in there taking a look, and whatever works for that physician tends to work more. Some of it's anecdotal. I mean, in regards to there's studies that show that they're all pretty much equivalent, the preps. But it really depends on what works for you and what you're seeing in regards to the preps.
We want you happy.
Well, and then we'll also have, and I know Dr. Denby has had the same situation where a patient comes in and they'll say, I just cannot tolerate what I tried, 5 or 10 years ago. Is there another option? And certainly we understand that we try to individualize the care that we provide. So if a person just cannot tolerate a previous prep, we'll try to find another option for that individual. And there are several options available. So.
Okay, good. Because that's the resistance I get when I'm doing cancer education and talking about screening. That they don't want to deal with that day. So I just wanted them to hear it from you.
When that comes up again, tell them that there's, although frustrating and annoying that it goes on for a day and a half to 2 days, just make sure you mention them. It's a lot less cumbersome than dealing with cancer for colorectal cancer or
Absolutely.
all the chemotherapy and things that goes on. So I always try to stress, compared to the two evils, I think the prep isn't that bad.
Yeah, I lost a dear loved one a few years ago to this cancer, and I do share that when I'm doing my education, because when you've seen someone and you've lost someone that way, you want to make sure that knowing going for this screening that you can prevent that. Why wouldn't you do it?
Sure.
Exactly. Okay, we talked about screening guidelines beginning at 50. So is that pretty much for everybody, the whole population?
No. There's certain people that can be done earlier. It depends, especially if someone has a colorectal cancer, and let's say in the first degree relative, which would be someone in their first level of their family, parents, siblings, children even. If they have someone who's got colon cancer, you sometimes will have to do it at the age of 40.
Okay.
Even some people with hereditary cancers, something termed familial adenomatous polyposis. Don't make me say that twice. Too fast. They can actually have a colonoscopy or flex sig even earlier, just to make sure there aren't any polyps and they're not at risk. And there's several different. I can give you a bunch of different acronyms for these different cancer syndromes, but the premise is depending on what the risks are, sometimes it's even earlier. But just remember, if you cross the 50-year-old threshold, you need to be thinking colonoscopy.
Okay.
So.
Now, we've had some famous people bring to light the cancer occurring in younger people. I know Katie Couric's husband was under 50 when he was diagnosed, and there are some other instances of people even in their 20s. How often does that happen?
Well, we definitely know that this is a maturity onset disease in general. And with that said, the younger people that are fairly famous that have had difficulties with colorectal cancer, it still occurs. And although it's very rare, for those individuals, the only way that we would know to adequately screen them would be if they were to develop symptoms that were worrisome. And unfortunately, polyps that grow in younger people, we're thinking that tend to be a little bit more aggressive. And unfortunately, when these polyps grow into cancer, that's when the symptoms develop, and that's when those people are ultimately see a gastroenterologist. So it's difficult because this is a maturity onset disease. Unfortunately, some younger people do develop these symptoms and thus colon cancer.
Okay. Well, you mentioned symptoms.
Right.
Could you list or share some of the symptoms that if a younger person, I guess, or anyone, but especially someone under 50, what would they be, and what should they? How long, should they expect to have them before they really know they need to seek further attention?
They're typically called warning symptoms or red flag symptoms. Basically, when they develop things like weight loss, bleeding in their stools, change in bowel caliber, which is a nice way, a nice dinner conversation topic. But if things are just starting not to move like they should, and unfortunately, a lot of the times these symptoms are pretty nondescript. And they can be kind of easily pushed off to the side. Maybe it's just hemorrhoidal bleeding, or maybe just different diet is changing their stool caliber. So sometimes it's really tricky to find these guys, these people with this early cancer, early onset cancers. And that's why you got to be vigilant. And that's why we do a fair number of colonoscopies in younger people
Sure.
without other risk factors, but they give us these warning symptoms.
And I think another one to go further than that was unexplained abdominal pain in a particular area that persists. Now, I mean, obviously everybody's had pain on and off in their adult life, but pain that persists in a particular region of your abdomen would be also a concerning sign of something maybe problematic. And then the other thing that we get sent a lot of patients for is unexplained anemia. If somebody is low on their hemoglobin or hematocrit, their family doctor picks up on a screening exam of their blood, and it just, why is the blood low, and could they be bleeding from a cancer in their colon or somewhere else in their GI tract? That would be another indication or a warning sign where we get sent patients for that.
Okay.
And the final thing would be change in bowel habits.
Right.
But that could be listed by several different
Sure.
things too. But
Sure.
sometimes we'll do that looking for Crohn's disease and ulcerative colitis as well as looking at polyps and cancers. So.
In the younger folks, are they typically pretty good to come in when they have symptoms that, when they occur, or are they typically the ones that put it off? And I mean, I don't know. Is there a way to?
I've seen both.
Is it both?
Yeah,
Yeah.
I don't think there's a generational feeling that more mature people are more apt to seek medical care because there's a lot of older people that doctors never even told them to have a screening colonoscopy. On the other hand, maybe younger people don't think that they're invincible, and that they can't have something bad. So I think we see both sides of that story.
Okay. We've talked about the test prep. Could you describe what would the day of the procedure be like? When the patient comes to the facility, can you just walk us through what might happen? And the reason I ask, we're trying to alleviate fear and to let people know that they're not going to be embarrassed. But if you could just share what would be expected.
Well, I could probably go through the whole scenario of what happens. They'll usually be referred to a gastroenterologist. They'll typically be seen in the clinic by either the doctor or a physician extender, just to try to expedite the process. Then they'll be explaining the procedure, they'll sign the consent, then they'll go ahead and start the prep the day before the exam. The next day they'll show up at the endoscopy center, and typically they're brought into the room, they're asked to change. They start an IV, because although people don't like IVs, it's good to get the sedation medicines in there. And then we typically roll them into the room. The procedure itself usually does not take more than 15 to 30 minutes. Then 30 minutes would be a long procedure. But the procedural length can be varied by how many polyps are found and the difficulty of the colon. But typically, after that, they come out of the room, they wake up from their medications, they don't have any ill toward effects. And once they're up and moving around, they can start getting ready to leave, and they can actually eat that day and things like that too. So that's pretty much the day. Usually by the early afternoon, they're out of the hospital and they're starting to eat.
Starting to feel good. Now, will you go and speak with them after the procedure, or will someone, so they have an idea of what the results are of that exam, or do they have to wait? Or?
We usually like a family member or a significant other to come with the patient, not only because they've received medication and they're not allowed to drive because they're somewhat still sedated after the exam, but also that gives us a forum to allow us to speak with the family member, the significant other, about the exam, what we found, what our plan of action is for that individual, and when to have that person follow up. And so that generally that individual can translate to that patient when they're more alert later in the day.
Okay. I have another question back on screenings. You mentioned the fecal occult blood test. The colonoscopy is an expensive procedure, or it can be, and for folks who are uninsured, and I get this question, what do I do? And would it be appropriate to refer someone for that, to start with that first line screening? I know it doesn't rule out everything, but
I think the better way to answer that is you look at cost effectiveness of that. It's a very cheap test. It's not really enjoyable to get stool samples and put it on a card, but after that bit is over, it's pretty much straightforward. It's not the most sensitive and specific test. What you need to do is you need to do three different stools and make sure the stool preparation is very important, and making sure all that. What they found is people who do the fecal occult blood tests and they've returned positive, their chances of finding colon cancer in those people is improved drastically compared to the people who don't do it. So the premise is so now you're trying to compare that with a colonoscopy, which not only is a screening test, but also is a preventative tool. And so it's hard to really compare them, but they're both very helpful. In fact, there's some studies looking at doing a colonoscopy and the stool studies to help increase the chance of not missing a polyp or lesion or cancer or something like that. But it's hard to compare them both. It's not like you can use them as equivalents.
right. I guess my question is, for those folks who just won't even seek the colonoscopy because they're concerned about the cost, is it good to at least start?
I think the problem there is that there are so many times that a person can actually be tested, and even if they had a cancer with 3 cards, there is this definite possibility that cancer bleeds, that colon cancer bleeds intermittently.
Okay.
That even if they had the 3 cards done correctly, they still all could be negative, and that person could still have a colon cancer. So we personally feel, and I mean, if I'm wrong, correct me please, but I personally feel that those occult blood tests or occult stool tests are good screens, but I think that colonoscopy is really truly the gold standard, and I don't think you can hang your hat, as they say, on a negative occult stool testing.
Don't remember the exact percentages, but those people with cancer, they did a study and it looked like the first card, I think it was like 20%,
Right.
would light up. Then you started getting to 30 and 40%, and then the maximum you could get with a fecal occult blood test with 3 cards was 50%. So you're still missing
Okay.
50%.
Right.
Okay.
I don't know the
And
exact
that's truly
numbers, but it's
amazing,
close.
considering if you
Yeah.
had colon cancer and you did those 3 cards, you could not pick it up in those
Yeah.
50%. That's truly amazing when you think about that.
It is. It is.
So-
I had not heard that.
Yeah.
We're running out of time. We probably need another 30 minutes or an hour to keep talking, but what I would like to do is give each of you a chance to kind of give the message that you would want to give to anyone about screening, about colorectal cancer. What is the final thought that you would like to leave with folks that are watching us today?
Go ahead if you, I'll fill in the gaps.
Basically, the screening colonoscopy at the age of 50 is vital to not only decrease the risk of colon cancer for the community, but also for the individuals themselves. I mean, if you look at it from the perspective of which is more of a hassle, I think having colon cancer and chemotherapy and radiation and having to wear a bag on the side of your belly because of colon cancer, going through a screening colonoscopy at the age of 50 is really not too much to ask.
And then also, I think, paying attention to your symptoms. If you've not had a screening colonoscopy, or if you're younger than 50, please, pay attention to, the symptoms or the red flags that we've talked about earlier about unexplained pain or weight loss or anemia or bleeding in your bowels. And I think that's just pay attention, talk to your family physicians, and see what they have to say. And if don't be scared of having a colonoscopy, because it really does save lives.
Okay. One other thought that I want to bring out to prevention. We've talked about screening, and we know the prevention is removing the polyps. But are there other things that we can do as far as lifestyle?
A lot of studies looking at it, not a lot of clear-cut answers. Folic acid is one that's been looked at with people with inflammatory bowel disease, which may have some preventative effects, but to be honest with you, we really don't have much answers for that yet.
Okay.
I think the key, like we were saying, we don't care where you get it done. Get it done by a gastroenterologist who's been trained in knowing what to do, and get it done at the age of 50 is the key.
Okay. Okay. I've seen some information about high-fat diets. In fact, that I saw one statement that the folks that live in communities that have the highest fat intake in their diet have the highest incidence of colorectal cancer. Seen anything like that?
I think you can just look at different countries in the world, and those individuals that are on more of a high-fiber diet and less fatty foods or less red meat tend to have lower incidence of colorectal cancer. And so we just don't understand, though, in the environment what turns on these cells to develop these polyps. There is suggestion that there's a connection with fat intake, and then the other risk factor that I think is fairly clear-cut is smoking. And smoking is obviously a risk factor for many disorders and cancers, but there seems to be a connection with colorectal cancer. I don't know if you have more.
Okay.
I just actually read an article that's talking about different types of fat intake maybe impacts different. And the whole premise is in about 15, 20 years it should be a lot clearer. But right now the data is still, we're still looking and chewing through a lot of data to figure out what's really going to turn out to be increases people's risks. So.
But just general healthy lifestyle messages, because as a prevention person, I'm out in the community, so it's okay if I say low-fat diet, good physical activity,
Sure.
staying active,
Sure.
and of course not smoking. All of those things would be appropriate messages to share with our community. Okay, good deal.
We mentioned the whole thing about COX-2 inhibitors. And
Go ahead.
There used to be a premise that COX-2 inhibitors, which is a certain type of medication to help with arthritis, would hopefully have some preventative effects, and it turns out it's probably not going to be the case.
Okay.
And it's actually, in some syndromes, it actually has some beneficial effects, but for overall people, there's some thought that maybe aspirin would have some preventative effects, and this time the jury's still out on that. So.
Still out. Okay. Well, March is National Colorectal Cancer Awareness Month, and I know we'll see some of our national spokespersons talking a lot about this particular cancer. In fact, we saw Katie Couric's colon on the Today Show, and you know, we could probably try to find somebody in Paducah to see their colon. But you know I appreciate you being here so much today and sharing information. You are the experts. And I think you're sharing a life-saving message of having that screening colonoscopy at 50 and making sure that you're in tune with your body. Those are all wonderful messages. And we just appreciate you so much for being here today. One last question. We've talked about many things today, but what are some of the areas of resistance that you've seen from folks with this particular cancer?
Well, I think that there's an embarrassment issue. Particularly, I think that men are a little bit less apt to seek medical advice. And so I think the embarrassment of, hey, I'm going for my colonoscopy today, and I think that that would be one of the major hindrances. But I think that people are trying to realize that this is a life-saving procedure and that they really shouldn't be embarrassed. I mean, we're professionals in what we do. We try to keep everybody comfortable during the procedure, and I think that the knowledge of having your colonoscopy and the understanding of that it's not uncomfortable can really hopefully decrease some of that anxiety that people tend to have.
The other bit of resistance is people feel like they're healthy, they're doing well. Why should I go get a procedure done? And typically the people I find the big polyps said, I didn't have any symptoms, doctor. And they said that's the purpose of screening. Screening is looking for a disease that you wouldn't otherwise know you had. For example, women are comfortable with this because they get pap smears every so often. Breast cancer screening, all those kind of things.
Right.
So this is just one of the other screening tests available.
Right. Great. Thank you so much. Dr. Carter, Dr. Denby, I appreciate you being here as my guest very much. We have some very good life-saving information that we've shared here today. If you have questions about colorectal cancer or other cancers, feel free to call my office, the Kentucky Cancer Program, at 442-1310. I'll see you next time on Better Living for Better Health.